My name is Lynn Yonekura, and I'm the Director of Community Health at California Hospital Medical Center.
I'm Robert Morrison. I'm the Director of Programs at Housing Works.
How did things come about for you where you landed in the medical field?
Well, ever since I was 4, I wanted to be a doctor because I was sort of sickly, you might say, when I was a kid and was at the doctor's GP's office all the time. And originally I said to his nurse, I want to be just like you. And she said, no, you don't. You want to be a doctor. And I said, why? Because I liked her. And she said, because the doctors give the orders. So at any rate, so I set my sights on being a doctor, not knowing the difference in training and so forth at that age. Went to USC Medical School, where there was a very good obstetrics and gynecology department. So I stayed there for my residency training, and I really loved the patient population we cared for. Then I went to Washington, D.C. for 2 years to do fellowship in maternal fetal medicine, which is basically high-risk obstetrics, and returned back to LA County, USC to do my dream job, which was running the labor and delivery service. And at the time, we were delivering almost 18,000 babies a year. In order to do that, sometimes there were long waits. In reviewing the types of patients that came to the emergency room, it was clear that one group of patients really belonged in more of a urgent care setting or, setting where they could get non-critical issues taken care of, whereas the rest of patients needed to be seen in the emergency room. So I set up a separate sort of an urgent care just during the swing shift, when most of the patients had rides. And so that immediately decompressed the emergency room, making it a much safer place. All the women that needed just pregnancy test or had mild problems could still have their care received. Eventually, after 6 years, I was appointed to become Chief of Obstetrics and Maternal Fetal Medicine at Harbor UCLA, another county hospital. I went to meet the head of the neonatal intensive care unit to introduce myself and say that I wanted to work collaboratively with her and, so on and so forth, and made the mistake of saying, well, if there's anything I can do for you, just let me know. She said, well, as a matter of fact, there are all these cocaine-exposed babies in my NICU, and they're all premature, and we need to stop this because we're in the middle of the crack epidemic back at that time. So the first thing we set up was a prenatal clinic for women who were using drugs and alcohol during pregnancy. It turned out that I was trauma-informed before that was even invented.
And harm reduction.
Right. They were full of advice. I had plenty of advice. We need this, we need that. And my research nurse was available to them by beeper 24/7. So they felt like they had a lifeline. And the first year, without even offering formal treatment, but just seeing them every week and staying on top of their needs and trying to address issues that they wanted taken care of, about 95% of the babies were born drug-free at full term. I mean, it was an amazing turnaround. So for the population that came to the clinic, they had good outcomes. There was still some that, didn't seek prenatal care, didn't know we had a clinic, and they still delivered preterm. So we tried to help them after delivery. The following year, we set up a infant follow-up clinic to do developmental testing on the babies to see if they needed any special treatment, having been cocaine and other drug exposed. And then ultimately, I got funding to set up a treatment program in 1990. Around that time, Senator Pete Wilson was in town. He was going to have a press conference in the hospital auditorium telling everybody that he was going to introduce legislation that would criminalize any woman that used drugs or alcohol during pregnancy. It's going to put them all in jail, take away their babies, and then after they ultimately got out, which I don't know how long the term was going to be, they couldn't socialize with anybody who used drugs or alcohol. I said, well, that's going to be difficult because that means they can't socialize with their family and they can't socialize with their congressmen and their senators. He was determined, and I tried to talk him out of it beforehand, but to no avail. So I rounded up a group of my graduates. I can't convince this man that this legislation is not going to solve a problem. So I'm going to leave it up to you to talk to him. So he was supposed to have sort of a photo op with this group. He went into the conference room where they were all there, and they were there with their babies and young children. They were all dressed up, An hour later, he was supposed to spend 10 minutes. Hour later came out a changed man. He said, I can't believe those women used drugs or alcohol. They didn't look like addicts. I said, well, that's because they're off drugs and alcohol now. They're rehabilitated. And what they told me is, if I went to an obstetrician and tried to get prenatal care, an obstetrician wouldn't take care of me because I'm too high risk because I use drugs. If I go to a drug treatment program and try to get treatment when I'm pregnant, no drug treatment program will take me because I'm too high risk. So how am I supposed to get prenatal care and get off drugs and alcohol if nobody will accept me into treatment except this one place in Torrance? He later promised me that he would do anything to help me with my work, which was very fortuitous because I needed a federal waiver to use drug treatment dollars toward a building for my program. So I called him up. There's a problem. I need a federal waiver, and it takes 6 months. And if I don't fill out all the forms correctly, it goes back to the bottom of the pile, and I'll lose all the money. 15 minutes later, I had a federal waiver in my hand. So we purchased trailers and still use them today. Ultimately, when he became governor, he set up, we're called Options for Recovery. He set up Options for Recovery throughout the state. And we had a network. We work with residential treatment programs, other outpatient programs, methadone programs. We built sort of a comprehensive network to really meet the needs. And because the majority have mental health needs, as you know, from a lot of childhood trauma, they were really using drugs and alcohol to cope with that trauma. And so what they really needed was therapy. So we've added an extensive network of therapists that we partner with so that we make sure that the patients get that need met, because if it's not met, they'll go back to using drugs and alcohol.
I feel like that's such an incredible story because it really is a testament to what we are doing in the sector currently with regard to the needs that human beings have. And in some instances, kind of helps them quicker than having to navigate larger systems. Mm-hmm. And so I think that's such a beautiful story that helps illustrate exactly why it's so special to me that this year you have been recognized for this particular award. And Robert Morrison was the one who suggested that we select you for this particular award. And so, Robert, I'd like to have you speak to the collaborative efforts that Housing Works has done, and is doing currently with the folks at California Hospital which is where Lynn has spent a very, very large portion of her career at.
Yeah, I think the collaboration that we have with California Hospital has been one that's been going on for what seems like forever. I think we've been working with California Hospital since at least 2012. I came to Housing Works in 2013, and we've been working with with our partners at the JWCH and previously the Corporation for Supportive Housing and now Common Spirit to have a FUSE program, which is a program really committed to serving frequent utilizers of the emergency room and hospital at California Hospital who are homeless and in need of support, just getting housing and access to other services. I've been really blessed through this process of getting to know you even a little bit better to learn about all of the other work that you've done in your life. It's just really, I think, speaks to who you are as a person, because I've always just kind of been, trying to make things work the best we can for the FUSE program, and know that you've been one of our biggest supporters and cheerleaders at California Hospital. So I'm just so grateful for, what you've done to support the growth of that particular project and all of the people that we've been able to house and support into, a better life because of the FUSE project. So I think the population we serve at California Hospital, I think you have to think about California Hospital and where it is. It's the closest hospital to the place we call Skid Row in downtown Los Angeles. So when you think about all of the urgent medical needs and everything that can happen in Skid Row, California Hospital is the closest place that people can go. And the people that we're working with California Hospital are part of what we call the 10th decile, the top 10% of utilizers of emergency services in that area. And so they're folks who typically have a lot of need for support, who typically aren't able to really stay at shelters because of their medical needs, who sometimes though don't really qualify to go into even higher levels of care because of the types of medical needs that they have. And so we're really engaging with folks who are in the hospital, trying to get them connected to permanent housing and medical services from the streets.
Lynn, can you talk to us and describe to us what it's like on your end to collaborate with an agency like Housing Works?
Well, I think it's been a great collaboration. At the beginning, we didn't have a whole lot of money to fund the project. I saw the outcomes from the initial pilot project that was done throughout most of Metro LA with many hospitals. And when that funding through the Corporation of Supportive Housing ended, most of those projects dissolved, which was really sad to me, just because a good working system had been established and it wouldn't take that much to keep it going. And ultimately, what happened is when Dignity Health merged with Catholic Health Initiatives to form Common Spirit Health, the California Attorney General mandated that we set up a $10 million homeless fund to address some of the tremendous needs of Californians. Now the project is funded by our Homeless Health Initiative, which is certainly Dignity Health wide, because if the hospitals in California don't see enough patients that require financial aid, then the difference between what we used to provide and what we are providing for financial aid goes into the $10 million pot. So we keep adding to the pot, basically, as more and more Californians become insured through the changes in Medicare, Medi-Cal. We have that gap of financial aid that we keep adding. So we were able to fund the program at a much more appropriate rate. So we have 2 full-time navigators working in the hospital through JWCH, and then you have additional staff now to help you. So, I mean, it feels good that the program is now funded appropriately, and then we have Nicole Wilson to make sure that all the partners are talking to each other. And so it's having a full-time coordinator to take care of the management of the projects.
I think right now we serve about 36 people through the 10th decile part of the project. And the other part of this partnership is JWCH, who anybody that's not in that 10th decile gets referred through services at JWCH. They have a clinic in Skid Row. And so we're really working to connect patients who are homeless to services regardless of their need. But I think with where we are right now in homeless services in Los Angeles, the system is itself kind of undergoing a self-examination of how do we prioritize people for permanent housing, kind of knowing that we have so many people who are homeless and we only have a limited amount of permanent housing. How do we make those choices? How do we decide who gets housing? I think one of the things that the Fuse project speaks to is the importance of, partnering with places where vulnerable people show up and connecting with them when they're in that moment of need so that we can build that relationship and rapport and help people move from that really acute environment into safer environments over time. As opposed to some models where you're trying to assess somebody's vulnerability, and then at the moment that housing becomes available for them, go back out into the community and find them, which can take a lot of time. And then you're trying to start from scratch with everybody. So the Fuse model is really about connecting at that moment of need, building that relationship and being there so that we can navigate people through that system to get what they need.
Right. And Lynn mentioned, she said something so key just now. She said, if it's not working, we look to figure out what we need to do to make it work. Robert, talk to us about why that is so important.
Well, it's so important to be able to have a real-time way of identifying challenges and resolving them, because the needs of the people that we're serving are so complex. And the ways that our system cares for people are also very complex, and they don't often meet up in the ways that we want them to meet up. And so if we're not talking about them and identifying them and really trying to elevate the challenges from not only the people who are participating in the services, but the people who are directly providing the services, then we're going to miss things. People are going to miss out on the support they need, and people are going to end up back in the hospital. They're going to remain sick, and they're going to continue to decline. And so our partnership with the team at Common Spirit is really important in our ability to be able to solve those challenges day to day, because they change so often. And I think just hearing more about Lynn's experience working with children and mothers who were using cocaine, or children who were exposed to cocaine, and her efforts back then to actually survey and ask, like, what is it that you need? I think it just speaks to the way that we need to provide services today to people who are homeless. We need to make sure that we're going straight to them right now and saying, what is it that you need, and designing our services and support to meet those needs.
We have served, Housing Works has served 36 people in the last year, right? Of those 36 people, how many have been housed? How many have passed away? Talk to us about those 36 individuals and what some of their stories look like.
Yeah, I mean, I'll say the population that we serve through Fuse, it can be really challenging to work with folks because they are so ill. And so we do have people who pass away while they're in our services, which is difficult, obviously for those individuals and their families, but also for our teams that support them.
Sure.
People, we're really out there, really making sure that we're getting in, staying in communication with people and staying in touch. So when people pass away, it can have a really poignant effect on the way that the team is able to operate. We've had a few people pass away in the last year, some while they were still homeless and some after they had gotten housing. And so that's very difficult. I think in the last year we've housed, I think we've moved 10 people into permanent housing out of the 36 this year, and we have a few more that are really close to getting permanent housing right now.
Lynn, I want to shift over and talk to you about what it has been like as a Japanese woman in this field. I know that's a very broad question, but I want you to just talk to us about what that has been like for you.
When I was growing up, I was a competitive ice skater for most of my youth. So that's a very solitary sport. And I was fortunate, I was very successful, but I knew I wanted to go to medical school, and my coach totally supported that. And I came from a very small girls' school. So then I went to Pomona College, co-ed. That was one challenge. And it was the girls' school I went to. I was the first non-white person to ever go there in its 100 years of existence. So I went to Pomona. It was a lot of big fish in a very small pond. And, I was happy with the B's I was getting. I felt like I'm surviving. But one of my chemistry professors called me into his office after the first semester and he said, "Lynn, I noticed you never ask questions at the question and answer session that we had before the test." I said, "Well, Dr. Nelson, the first row has the entire football team, in my opinion, and they're kind of intimidating looking. And I'm not used to having guys in the classroom to begin with because I went to this tiny girls' school. And I'm introverted, so, I just listen and take notes and do the best I can." And what he said changed my life. I know that for a fact. "Lynn, you would be doing me a big favor if you don't understand something, because it would give me an opportunity to explain it to the whole class. Because if you don't understand it, that means the majority of the people don't understand it either. They don't know that they need to understand it." So I started asking questions. I started doing a lot better. So I started slowly coming out of my shell in college. And then I went to USC, and compared to Pomona, medical school was easy. I don't know why, but it was. So, and I really liked, it was a pass-fail. It was the only pass-fail system in the United States, and that's why I picked it. And their philosophy was, if you're smart enough to get into medical school, you should be smart enough to pass. And so we worked collaboratively. I went into OBGYN, and that was a bit of a problem because it was a male-dominated program. There were no women at that time, or there'd be one, and then there'd be this huge gap, and then maybe they would hire another one. But I had the benefit of working with this wonderful OBGYN, BJ Gregorius, in Toluca Lake during the summer one year when I was a medical student. So she was sort of my role model of how you could do this. She said, don't mind the boys, just ignore them. I went into this set of interviews to get into my residency program, and I was a student there, so they all knew me, all the professors knew me. Whereas if you came from out of town and you were male, you got 2 interviews. I was a student at USC and had taken all these extra classes. I had 8 interviews in one day. Nobody could be interviewed like that now. They would be sued. Because the first question at 8 o'clock in the morning, I had my cup of coffee in hand, having worked all night, was, "I suppose you're going into OBGYN because you're a lesbian." At which point I dropped my cup of coffee, went all over the professor's desk, and I said, "No, I don't happen to be, but even if I was, shouldn't make a difference as long as I don't molest any patients," which I don't plan to do. It sort of went downhill from there. Before lunch, a professor was pounding on his desk saying, "This is a man's field. Women don't belong because we operate and only men should operate. Everybody knows only men should be surgeons." And I said, "Well, obviously we're not going to agree on this point, so why don't we just break early for lunch?" So the last interview was with a chairman of the department. And he said, "Well, I don't see a way to keep you out because your grades are good, but I don't want you to get pregnant while you're a resident." I said, "Don't worry, if I get pregnant, my mother will kill me first." "You don't have to worry about it." He said, "No, I'm going to make sure you don't get pregnant." I said, "Oh, okay." So he took me downstairs to, he was he did a lot of research around contraception. So he says, my research nurse is going to put an IUD in you, and you have to keep it in while you're a resident. I said, okay. So I felt like that was my ticket to get in. But, again, this could never happen today. I have a lot of funny stories. Like when I was chief resident in gynecology, they said the sleep room for the chief resident, you had to go through the men's bathroom, the men's changing room, and in the very back of that was a locker room for the chief residents and a bed. So that's where you're supposed to sleep when you're on duty for gynecology. I said, well, that's not too convenient. He said, well, that's your sleeping room. If you want to sleep, that's it. I knew if I complained, then I'd be labeled the B word. So I decided a different strategy. I slept in the intern's room during the night and instead of the chief's room. But I went in there in the morning about 6:30, and I put on my makeup and, fixed my hair and brushed my teeth and everything. When I heard all the doctors out there in the changing room getting ready for surgery, it starts at 7. And these are outside physicians that come in and operate mostly with our residents. I open the door. Good morning, Dr. So-and-so. Nice to see you. Good morning. So nice of you to come to operate with us, And I go waltzing through the changing room and the bathroom out the door. And I got a phone call a half an hour later. We're making a new chief's room for you, Lynn. It's downstairs. Be all to yourself. So sometimes trailblazing has its glitches, but I just tried to not let it get under my skin. I made it more of a joke because that way I get things taken care of, but without being labeled. And just like in the chief's sleep room for obstetrics, that was again off the men's bathroom, but the good thing was it had an outside door. So that was fine. I walked in there the first night and I noticed that there's Playboy bunnies all the way around as a border print around the top of the room. And I thought, good Lord. I went to a used bookstore on my day off and I got all these I forget what it was, magazine that had men. And so I pasted up the border print of men underneath all the women, And the guys came in the next day and they were just, Lynn, that's ridiculous. And I said, what? That border print you put up, you got to take that down. They said, that's just pornographic. And I go, what? They took down all the border prints voluntarily because they wanted to get rid of mine. And they knew if they got rid of mine, they had to take down theirs too, which was my goal in the first place. But they were the ones who initiated it. So I'm not the quiet, typical Japanese woman that my grandmother was, for example. I'm much more outspoken. But I think, some of that comes from going to a girls' school where girls do everything. That's what you learn. Girls can do anything, and at this school they have to do everything. So the biggest lesson I've learned over the years since I started that drug treatment program down at Harbor is that there's much more joy in collaborating with like-minded partners because you're all working together for a common cause, and which is why I enjoy working with Robert and the team at Housing Works, and people from JWCH, because again, as you said, homelessness and the people who are experiencing it is so complicated. There's so many problems that need to be addressed that no single agency or person can do it. So it's got to be a collaboration.
And as we bring this conversation to a close, because I could spend all day with you, Lynn. And when I had my initial phone call with you, I got off that phone call so inspired. And so I just want to say thank you for what you have done for society over the course of your lifetime, and what you are going to continue doing, because you just strike me as someone who's not going to stop until the universe says it's time to stop. Lynn Yonekura, we want to thank you. On behalf of Housing Works, we want to thank you, the 2022 Tom McGuiness Award recipient, for all you do for our community.
Thank you for all you do.